بروفيسور فرانشيسكو دكتور سامح، بس حضرتك ابدأ بقى.
Okay. Professor Francisco, you are very welcome. How are you?
Thank you for your kind invitation. I'm also very happy and proud to be with you this night.
You are very welcome. And everybody here is waiting for you, and all the participants are very happy to have you with us tonight. You are very welcome. Okay, today is the second wave of Al-Azhar bifurcation course. We have discussed the basics of the bifurcation disease and the physiology and the anatomy of the bifurcation lesions and classification last week. I would like to welcome all the participants and to welcome Professor Mansour Salam, Professor Abdul Maqsood, moderators with me. And tonight we have two talks. The first talk is Professor Berjuta, and the second and then we will open the door for discussion. If you have any question, please don't hesitate to write it, and we will try our best to answer all the.
There is a problem with Dr. Sameh?
Yeah, I think so.
Hello?
Dr. Hello, Professor Francisco, how are you?
I'm okay. So I'm ready to share with you my presentation. I am really happy to be involved in this bifurcation course. I know that you are going step by step, and today we will cover. I understood that we will cover mainly provisional approach. So if you want, I am ready to start.
Okay, first of all, I would like to thank you so much, Professor Francisco, for your kind acceptance to be with us today. Professor Samih Alam, he is the head and leader of continuous medical education at Al-Azhar University. Professor Mansour Salam, intervention cardiologist, and he received his first training in intervention cardiology in Milan with Professor Antonio Colombo. And I will be with Dr. Samih and Dr. Mansour, and the second speaker, Dr. Ibrahim Yassin. So I will leave the moderation of the talk for Dr. Samih and Dr. Mansour, and we will enjoy your talk, Professor Francisco.
Prof. Samih, please.
Go ahead, Mansour. Go ahead. Start the meeting.
Professor Francesco Presota, it gives us our great pleasure to have you in our course. I would like to introduce, or gives me pleasure to introduce Prof. Presota to the audience. Professor Presota is a professor of cardiology at Università Cattolica del Sacro Cuore, Rome in Italy. He is a senior interventional cardiologist at the cath lab of the Department of Cardiovascular Sciences. Fondazione of the Policlinico Università Rome, Italy. And also is a co-director of the master degree of the course in the interventional cardiology at the Università del Cattolica in Rome, Italy. Also, at the meantime, he is a coordinator of the valve heart diseases clinical pathway at the Fondazione of the Policlinica Università Roma, Italy. Professor Sotta, I have taken many tours in the beautiful city, the ancient city of Rome, but I think it will be the first time for us today to take a tour in the bifurcation lesions. So all of us, on behalf of the panelists and audience, we are hyper excited to listen to your journey in the bifurcation lesions. So the floor is for you, please, Prof.
Okay, so do you see my screen and the slides?
No, we are seeing you.
Okay, so
have you shared your screen?
I'll try to do.
Okay.
Okay. So here we go. Okay, do you see it?
Okay, you can start your, would you start your PowerPoint presentation? We can see the front page, but not the PowerPoint.
Do you see?
Not yet.
Not yet. Full, okay. Have you started the PowerPoint?
Yes, I started.
Is it available on your screen?
Okay, I redo the steps. Okay.
Yes.
So.
Okay. Yes.
Is it okay?
Slideshow. Yes.
Yes.
Okay.
Great.
You are.
So sorry for this delay. So I think that when we approach bifurcation lesion, we should have in mind the fact that the vast majority of the bifurcations cannot be avoided. So bifurcations are part of the job of interventional cardiologists because basically atherosclerosis develops at the bifurcation points. I mean, it's one of the areas of the coronary trees in which most commonly you have atherosclerosis. The problem of stenting bifurcation is really very complex, and this is why the European Bifurcation Club was promoted the improvement and standardization of bifurcation stenting technique. And I think that the very visionary work by Yves Louard was very important. I had the pleasure to be part of the group of people that started building a consensus regarding the techniques. And why this is deserved? Because I think that any interventionalist has his own approach to bifurcations, but it is also important to speak a common language when we treat the patients in order to anticipate what we are willing to do and what we at the end have been able to do. In this regard, the MADS classification is very visionary because it is based on the concept that when you start a bifurcation, you make a decision where to implant the second stent, but this is just the start of the work. And there is a flow of procedural steps that are needed to be performed in order to have good results. So regardless the type of bifurcation intervention we select, it will not be a successful procedure if we will not be able to complete the procedure we had in mind according to the technique. When we look at this chart, we realized the fact that there are some techniques that are just, reported in the literature, but basically the main decision is between situations in which we decide to implant two stents into the bifurcations since the beginning, or situations in which we follow a provisional approach. And provisional is not one stent. This is very important to be borne in mind, because most of the people likes to compare one with two stent strategies. But in doing provisional, especially when you are tackling the worst patients, you really need to adapt your technique in order to be prepared to implant a second stent. So provisional approach is not just one stent, is to start one stent across the side branch and then to go on till we conclude our results with good angiographic results. However, the benefit and the good thing of provisional approach is the fact that allows you to spare some two stents, because if you effectively treat a patient with one stent, you might have influenced positively the outcome of the patients. This is one of the meta-analysis. As a reviewer for journals, I continue to receive meta-analysis for many journals. The concept is that we basically have, for cardiac death, completely no signal favoring systematic two stents in the literature. Regarding target vessel revascularization, we have probably some advantage, but it is just, the process of restenosis and treatment, sometimes of side branches that have not been treated properly during the first time. And for myocardial infarction, we have again signals for improvement with provisional due to the fact that the procedure is basically shorter most of the time, and periprocedural myonecrosis is lower. And there is also the possibility across literature, this is one of the main reports that highlighted this, a meta-analysis by Marco Zimarino, showing that for stent thrombosis, there is some signal across literature in favor of increased risks with two-stent strategies, systematic two-stent strategies. So this is the background that we should have clear in mind in our procedure. So if we do not do good job with a single stent, we take the risk of patients coming back due to the side branch and ischemia. And especially if side branch is huge, this can be something that may be risky for the life of the patient. However, if we systematically stent all the bifurcations, regardless the complexity, regardless, the really need to implant to stent to have good angiographic results, I think that especially into the long-term outcomes, we have some additional hazard for the patient. This is a very last meta-analysis exploring the long-term outcome of patients exposed to provisional or to stents. And when you look at the very long-term results, you see clearly that there is a signal for mortality, especially in the long-term hazard with double stenting. And take in mind the fact that most of the trials that have been published have with two stents did not explore the very long outcome of the patients. When DAPT is interrupted, most of the time the patient can be exposed to other risks of, for example, interventions which are non-cardiac and so on. So this is, in my mind, a very strong background that tells you that if you are able to fix appropriately a bifurcation with a single stent, you should do. And in doing this, I think that there is a lot of improvement that has been achieved during the last years. So what is the main problem with provisional? The problem is that there is many ways to perform the provisional, so that there are operators proposing to perform a systematical pressure wire assessment. There is people saying that we should just dilate the side branches needed and so on. However, I think that it is important to be very consistent and to select the manipulations that are associated with increased chances of success in the hands of all interventional cardiologists. What I mean, we started performing crossover stenting, mentioning crossover stenting as the provisional technique. And in the case of needs to side branch, we just performed the rewiring. And in the case of further need, we performed ballooning and eventual stenting. This was suggested in the past. However, we were not happy with the results of this technique. And one of the things that we learned well is the fact that if you just balloon a stent to go to the side branch to open the cells, you induce a distortion that into the main vessel that creates malapposition on the opposite side. So this means that just ballooning the side branch, we jeopardize the results of the main stenting, and the main vessel stenting is the only stent we are doing. So this means that really that is something that jeopardizes what we were intended to do. That is at least to implant a stent well inside the main vessel. The proposed alternative was kissing balloon inflation. You see here an example. And there was no advice regarding balloon selection, regarding length of overlaps of balloon. I mean, it was just suggested to do. Now we know that there is a optimized way of performing provisional stenting, which is associated with a series of advantages. First of all, when you perform your provisional stenting, crossover stenting, we should select a stent sized 1:1 to the distal main vessel size. Why to do this? Because we want to avoid displacing the carina. And this should be followed by a precise, systematically needed step, which is POT, which is dilation of the proximal main vessel with a balloon which is sized 1:1 to the proximal main vessel. Then, after POT, you have this situation. I mean, after crossover stenting, you have to anticipate that there is a huge malapposition here. And if you perform a POT with the balloon which is appropriately placed, you have an area which is post-dilated, an area which is non-post-dilated, and a transition zone. Well, when you look at the response of first generation drug-eluting stent to this maneuver, you see this result. But the last generation contemporary drug-eluting stent have a response which is particularly favorable, because in the transition zone, you have really the opening of the struts, which is much more efficient as compared to this. And a series of bench tests documented that the opening of the side branch, when you precisely placed your POT balloon, is so effective that sometimes with kissing balloon inflation, you have just too few improvement to be gained. This is very important in my mind. This is a case appeared in our lab. You see definitely that this is a tightly stenosis diagonal branch with long disease inside the main vessel. After main vessel stenting and POT, you have a situation like that. For sure, the main vessel is perfect, but this result is not good. So what we need to do to have a fantastic result here is to keep attention not on the dilation of the struts, but first we need to keep attention on the rewiring phase. In particular, what we need to do is to engage this stent into the very distant portion of the side branch, very close to the carina. If we do this, only if we do this with kissing balloon inflation, we will achieve a result which is completely different. I will show in a minute. How to facilitate this step? The conventional rewiring is based on the fact that you advance your wire toward the side branch. We now know that this is a technique that is associated with very common non-distal rewiring. So it doesn't matter if you are selecting the wire that you have already advanced into the distal main vessel, or you advance a new wire, you should first go into the distal main vessel, and then you should go with an appropriately bended tip, and then you go step by step until the tip of your guide wire jumps inside the side branch. And if you have this, you will see that there is this distance between the radiopaque part of the wire that crossed and the radiopaque part of the wire that you may pull back. So this distance is the one that when you face during your interventions will tell you 100% that you are not proximal, probably very close to the distality of your side branch. And why are we willing to do this? Because if we go inside the distal part and we perform into the proximal part, and we have a different distortion between distal and proximal. So if we rewire here, it is distal, we will have some metal accumulated with kissing balloon inflation into the distal part of the bifurcation, and very few stent struts opening the side branch access. On the opposite, if we go distal, this is green rewiring site, you will have this scaffolding of the proximal main vessel, and you reduce the amount of metal here. This is very important in my mind because most of the time when we have bad results, it is related with imperfect result at the ostium site. And if we prepare the side branch like that, to add another stent will not be an issue, okay? So very important point. This is a bench test done at my university, and you see that performing exactly the same steps with the same balloons, wire, and stents, you have a completely different shape of the stent. If you perform a proximal reopening, proximal distal, you open for sure. There is good opening here, but you do not have this scaffolding that is very important when you have disease at the ostium site. So I have no problem with this in the case there is no measured disease. I mean, you open perfectly, but if there is a lot of disease inside this bifurcation, Medina 1-1 lesion, you really deserve to have this scaffolding, to have a good result with one stent, and to prepare for this, for additional stenting in the case result is not satisfactory. So here is the rewiring phase, and you see that even in no measure bifurcation, but very tightly diseased, you may have really a fantastic result like that. And this is the same stent exposed to the same manipulation. You really see that you changed your platform into a dedicated to bifurcation stent. So it is very important to have this image in mind, because I think that this may change the paradigm that to have a good result into not longly diseased side branch, you really deserve to add another stent. So we may really stent the proximal part of our side branches. And keep in mind, if you discussed the last time about the distribution of plaque, about the fact that most of the time the plaque is on the lateral part of the vessel wall. This means that most of the time we really took care about the most diseased part of the side branch. So this is what we say is optimized provisional. So main vessel sizing according to distal main vessel, POT, distal rewiring, kissing balloon inflation, and eventually a new pot to restore. This is another case, for sure, very tight lesion, but short disease. So this is a very good argument for a very good result with optimized provisional. So we did this, and this is the result. I think that there is no way adding a further stent to have a better result. So short lesion, even with tight lesion in the side branch, can be fixed in a stent-like way following these procedural steps. But we really deserve to give dedication to the appropriate way of doing and success in doing each of the simple steps I told you about. So if you have this in mind, you may look forward to have an extended use of provisional. This is a female 74 years old, classic presentation, inferior elevation MI, and LAD lesion on diagonal. This is the result, and this is the lesion. You see that here you have a dual LAD basically, because this diagonal goes down all over up till the apex, but most of the disease is in this diagonal, while LAD seems not to be so diseased. So if you are confident in this technique, you may also decide to use, to change your paradigm to consider the diagonal as the distal main vessel and the LAD as the side branch. And so radial approach, 6 French, inverted provisional, POT, final kissing balloon inflation. And this is what we did. You see that we wired both branches, we pre-dilated appropriately. Then we implanted stent for diagonal till the ostium of the LAD. This is the result. You see that there is some carina shift here that deserve correction. POT done before rewiring in order to prepare very distal rewiring. This is a pullback rewiring. We didn't want to remove this wire, so we added the one wire. We went, however, into the diagonal. Look at the curve of this tip that is very appropriate to engage the very distal strut. As soon as it enters the carina, the wire jumps inside. Then you may look to the distance between the wires. To see this, you just pull back your wire from the LAD, the jailed wire, and here is the rewiring wire. And then you apply kissing balloon inflation. This is the result. And this is 7-month follow-up for this patient. So for sure, this is not routine. I mean, this is patient by patient discussion. I mean, this patient had some issues regarding her adherence to double antiplatelet therapy. So there can be, I mean, a patient-centered decision into single or two stents, but to have in mind the fact that you may do something like that may improve your decision-making process. Other situation in my mind is this. You have definitely some distal left main lesion, but very tight ostial circumflex lesion and unremarkable LAD lesion. This is a very important bifurcation. For us, this may become the operative main vessel, and we performed inverted provisional, so stenting first here, then POT, distal rewiring, final kissing, and repot. These are the steps after predilation, POT, kissing balloon, the balloon very appropriately sized 1:1, and this is the result. If you have any doubt, you have the tools to understand if your result is fantastic or not. Here is the appearance of the stents, and we perform the OCT in both branches. You see here how opened is the LAD, and you may check if LAD has any kind of dissection. By OCT, we see very well. Here is carina, and here is ostium of the LAD, in which some stent struts are appearing. So very important, you see that the plaque was mainly on the lateral wall, and our stent from the circumflex was able to adapt and cover the plaque prolapsing inside the LAD. So this result is not just absence of disease, it is a mild disease that has been stented from the stent coming from the circumflex due to the fact that distal rewiring was very effective. And I mean, if you go on with that, you may expect the fact that provisional can be, I mean, different and differently complex as you move from very easy cases, which there is really mild disease and false bifurcation. The situation like that in which you have nasty disease inside the LAD, if you want to just with one stent, you should expect that the possibility to have occlusion of the side branch is higher, complications risk is higher. So provisional, when is applied to more complex procedures, deserve adaptations. But if you do, I think that it is possible to have these results, which are really impossible to be related with the differences into the baseline condition. And what can be the, the ideas we should have in mind while treating complex patients with a lot of plaque inside the bifurcation? When we perform crossover stenting, we have the problem of carina shift that is apparent by IVUS, and this is most of the time the cause of side branch jailing, which is the presence of stenosis which was not apparent at the beginning. However, there is the possibility, that when you have a lot of plaque, you have with crossover stenting plaque shift as well. And this is due to the fact that we perform this longitudinal enlargement of the plaque. And this is the cause of side branch occlusion. In other words, the prevention of carina shift is not the only issue. Plaque shift does exist. Now I hear more and more speaking about carina shift, but the main problem is still plaque shift when you have a lot of plaque around. We already knew, and it is important that we keep it in our mind. So what happens with the crossover stenting? This is Korean study, very important, showing that if you just implant your stent across a lot of disease, you may have impairment of the TME flow, which is quite common. And this is probably why most of the people is scared about performing provisional in nasty cases. But we should have in mind that side branch occlusion can be prevented. One of the strategy is side branch predilation. There is a trial by Manuel Pan showing that if you randomize patient to side branch predilation or no side branch predilation, patients with true bifurcations, you have reduced impairment of the TME flow with side branch predilation. So I think that this is something that is incorporated in the flow of double stenting procedures. But it is also important to remember that it can be applied inside the single stenting procedure when you have very complex lesions. So to predilate, to keep attention to predilation is important. And if you notice that there is dissection, you may change your practice and perform a double stenting procedure. But there are many cases in which you prepare the side branch very appropriately, and you may follow the flow of optimized provisional. And what we refined in our cath lab is the fact that when there is a really lot of plaque inside the bifurcation, you may consider to perform predilation with kissing. And the idea is that we do not only predilate both branches and see if they open or not, if they are calcific or not, if the balloon expands or not, but you may sequentially do this, but if you use a kissing balloon inflation at the end, you increase the space into the polygon of confluence by removing the plaque from the area in which the plaque shift is more probable to occur. So this is the sequence, and this study is published. This is an example of this study. You see that there is Medina 1-1 lesion with a lot of plaque. Look at the sides of this proximal bifurcation point. After pre-kissing, you have a completely different scenario. Completely different scenario. And the bio-CT, look how we move. This is the before intervention and after pre-kissing, how the plaque has been displaced. And this is the result after optimized provisional. So once more, stent toward the PDA, then POT, then kissing balloon inflation, really fantastic result into the both branches. And we also documented the fact that the need of the occurrence of impaired TME flow is much less with this technique. Final stage to improve safety of provisional is the possibility to enhance protection. We usually put just a jailed wire. However, it is possible that we enhance the protection by adding also an inflated balloon to this side branch, and we deliver the balloon with the stent with the balloon under the stent struts. And if the flow is good, we remove everything. If there is occlusion, we dilate. This is something we reported, but it has been also, I mean, evolved by other operators using microcatheter and so on. But I think that it is much more convenient today to consider using the side branch balloon rescue technique. What is this? It is something that in my practice really changed my perception about the efficacy of provisional. You see here that in the visible art, we are performing, we have a provisional with the jailed wire here. If we have occlusion of the side branch, we may consider using the jailed wire to advance a balloon a small balloon that is usually able to cross the stent, reaching the side branch. And you see here how it is step by step displaced, reaching the side branch. Then you may advance the balloon ready for POT inside the main vessel. Then you dilate the balloon in order to restore flow toward the side branch. And then, since you create a lot of malapposition, you have the balloon ready inside the main vessel so that you may perform re-POT for sure, avoiding reaching the carina. And this is the balloon which is inflated. You see that you create a distortion of the stent. So it is important that your balloon for POT is ready. And then you inflate the balloon. Sorry, you inflate the balloon and you correct this. I think that this is really important because it also allows you to eventually change your strategy. You may also consider, if you are a fan of crash, to increase the size of the balloon, crash the stent struts here, and complete, after having crashed the stent, to perform an inverted crash, and you continue with your procedure. So I think that this is enough for today. I want to just remember you that this technique is also very important in the case of entrapment of the guide wire. So if you have entrapment of the guide wire, you may advance the balloon. If the balloon is not able, before removing or pulling back forcefully, you may advance corsiror tornus to disengage the balloon. So altogether, these refinements are really able, in my mind, to improve the safety of provisional and to allow you to apply provisional to more complex conditions. If you follow all of these stages, so if there is a lot of plaque, you predilate both branches. You eventually perform a kissing balloon predilation, then you implant, then you perform a kissing balloon inflation with the confidence in all your steps. I think that even to implant the second stent, if you are not satisfied, into the side branch will be very easy. And in doing this, you have two techniques. You may complete with T or tap or to culotte. It is just a matter of length of protrusion inside the main vessel. So with that flow, I think that the vast majority of bifurcations may be treated safely. Thank you.
Oh, fantastic. Thanks very much for this very nice illustration of bifurcation lesion. Thanks very much, Professor Brizuta. And actually, I have some comments and I need to answer the questions of the audience. So if any of the audience, please, if you would like to ask, just feel free to ask Professor Brizuta with us tonight, and he will answer your questions. I learned from Professor Brizotta now that provisional stenting is in bifurcation lesion is the technique you start with. Choose the stent size according to the distal main vessel diameter. Put POT is mandatory. Rewire as close to the carina as possible. Distal in the distality of the side branch. Side branch occlusion is frequently caused by both carina shift and plaque shift. Side branch pre-dilatation helps to keep the patency of the side branch. If no dissection occurs, just to go and stent it. Uninflated balloon may be trapped behind the stent, so you can retrieve the gelled wire and you can redilate or reopen the side branch if it is totally occluded after stenting of the main branch. I think these are the golden rules I have learned today, and I have just written it and read it for you. The question now, if you are going to do POT for the proximal main vessel, do you stop or do you park the distal end of your balloon just at the carina, or it protrudes into the main vessel distal to the carina?
So thank you very much, because this is really a very smart question. First of all, you should know very well your balloon, because the shoulders of the balloon are completely different from a manufacturer to another. So there are some balloons that have very small and round shape shoulders, and there are other ones that are very, long point that, prevents you. So first of all, you should know very well your balloon. Then my rule is to try to be close to the carina, but if I have doubt of going to distal, I prefer to perform a POT to proximal. In other words, if you go to distal with the POT balloon, you increase the risk, or you induce systematically carina shift. If you do not reach the perfect distality, you solve most of the malapposition in the proximal main vessel, but you will not probably induce the best deformation of the stent toward the side branch. So this is a trade-off which is acceptable. I don't want really to go to distal and to discover that side branch get occluded due to my POT, which is incorrectly to distal. Okay, so in the doubt, I try to avoid the carina. Yes. But we know that it is more effective if you are closer to it.
Oh, thank you very much. The second question, how long you need to park the stent in the main vessel so you can adapt your balloon just to dilate the stented segment, and it should not be long enough to protrude proximally from the stent?
So I think that probably the most political response should be that you should have an amount of stent in the proximal main vessel which is at least long like your shorter balloon. This means that if you have 8mm balloon in your cath-lab, you really need to have systematically at least 8mm of stent into the proximal part.
No, that's good. Excellent. Thank you very much.
Thank you very much, Prof. Francesco, for outstanding presentation. Actually, you have added a lot of information that will generate a lot of discussion, I think. Do you prefer to start around discussion, or shall we start with Dr. Ibrahim and we will keep the discussion?
No, let us carry on, Mansour, with the questions, and Ibrahim has enough time to give us his talk even last time, next week. No problem. let us enjoy the discussion with Professor Berzot.
Okay. So first of all, please, all of you, call me Francesco, because I mean, we are peers. I like very much the idea.
That's good.
Okay.
We love doing that.
So a very, very nice presentation, Dr. Franco, or if you would like to make it more easier. Franco.
Okay, thank you.
Okay, so I think you have added many information regarding the bifurcation or concepts that will be changed. One of them that I first time to hear from you right now about the routine side branch dilatation. I think our concept from the beginning is it is discouraged in general to predilate the side branch. But right now you added information.
Let me explain a little bit better.
Okay.
What we feel that it is mandatory is to predilate the side branch, because most of the bifurcations are also, I mean, with a lot of plaque. However, when we are applying provisional to Medina 1-1 lesion with a lot of plaque, I think that instead of having the risk of having an occlusion of an undilated side branch, it is much more convenient to predilate it. We know that we take the risk of dissection. In the case we have dissection, we may consider to switch to DK crush or to other technique, but what I recommend not to do is to lose a side branch. And to lose a side branch, I think that the worst condition is to have occlusion of a tightly diseased side branch, which has not predilated before, and then you have to deal with the occlusion with both the stent in front of you. So in my mind, this is, and now we have the Manuel Pan trial showing that in true bifurcations treated by provisional, predilation might be effective.
Okay. Another issue also that I would like, or there is a controversy about the side branch wire. Which wire do you prefer to gel? Is it hydrophilic or polymer jacketed? Because the risk of damage, which one of them is more risky to use?
So honestly, we perform, I can say, 100% of our bifurcations with BMW wire. Okay, so and if I say 100%, it is really close to 100%, because sometimes we need an hydrophilic wire to wire very nasty side branches, but we do not like to gel side branch polymer jacket wires, even if we know that they are easy to remove. But most of these conditions are complex procedures in which you have to deal also with the risk of distal perforations. So even if I have a situation in which there is a nasty side branch and I have to wire first with an hydrophilic wire after predilation, before performing all the other interventions, I like very much to switch for BMW, and then I go on with that. And with the BMW, we really experienced, I mean, lot of nasty conditions in which there was no entrapment, but there are some advices for that. First of all, the BMW should not be, your wire should not be pushed too much. I mean, when we wire, we want to advance the balloon a very distal position and so on. But at the time of implantation of the stent inside the main vessel, it is very important that before delivering it, you just pull back a little bit your wire in order to do not have distal entrapment into the distality of the branches, small branches, angulations, and so on. Other point is the fact that we keep attention all the time, even in easy cases, before implanting the stent, to remove loops from the wire. Sometimes when you loop, you have into the distal part of the side branch, you have the wire which is looped. So we do not want to have a looped wire which is jailed. So all of these steps are part of our procedure. And last but not least, remember that if you select the stent one-to-one according to the distal main vessel, you will not jail the wire firmly unless you perform a POT. So further step is the fact that before performing POT, I check if the wire is free. And I pull back a little bit the wire so that I am sure that it is not distal entrapped, it is free, there is no looping inside the main vessel before performing a POT. And this is also important because as I mentioned you before, in the case you notice occlusion of the side branch, you have here very easy advancement of your balloon without a distortion of the stent because you didn't perform POT, so it is floating into the main vessel.
Okay. Francesco, thank you, Dr. Mansour. I want to the point of side branch dilatation to be clear for all of us. I went through your fantastic paper about the varying stenting technique. You did it on behalf of the European Bifurcation Club. And you mentioned, and your team clearly, if you will go provisional, so it's a mandatory to do pre-dilatation for the main artery. And the side branch, it will be optional if you will use one stent technique. Mm-hmm. But the second important message, if our plan from the start to use two stent technique, so it's a mandatory to do both, pre-dilatation for the main and for the side. So I mean, I want to concentrate about the side branch pre-dilatation. In provisional stenting technique, the side branch, it's optional for the operator. It's not mandatory. The mandatory, the main vessel pre-dilatation.
Yes, I think that you perfectly summarized, but we are here also to share experience. And I have to tell you that if I have a tightly diseased circumflex and I'm treating this left main, I will not, ever stent provisional from LAD toward the left main with the undilated and undulated circumflex before. So I prefer to have, a dissection and then to stent and perform inverted tap or inverted culotte, implanting the first stent from the left main toward the circumflex, being 100% sure that I will not lose the side branch.
Yeah.
If it is important, okay?
Yes.
How many times, Abdul Maqsood, did you change your policy during PCI bifurcation? We usually put a policy, and actually when you start performing what you would like to do, you change your policy according to the situation you face during PCI for bifurcation lesions.
Actually, okay, come on.
No,
Francisco, go ahead.
So honestly, I think that we are using in my lab almost 100% of provisional approach, regardless the complexity of the patient.
Yes.
So if you are using it systematically, this means that you use provisional flow to implant two stents, okay, as well. So this means that for me, if I start a left main procedure in which we start with the Medina 1-1 lesion or Medina 0-1-1 lesion, so both LAD and circumflex are diseased, I will not consider a change of strategy the fact that after having implanted the first stent, I need to implant the second stent. On the opposite, I think that my goal here is I have a huge bifurcation, I have a huge disease. If I will be able to have a fantastic result just with kissing, I will accept it. But if I will have problems, I will add a second stent. And in doing this, I will use most of the time TAP. And sometimes if angulation is unclear and I'm not 100% sure that my tap stenting is perfectly placed, I select culotte. So I think, so this means that I know that if it is diseased, I am open to implant a second stent, and I start doing it well, preparing the lesion appropriately. So if you think that provisional is a procedure step in which you implant first a stent crossover and then implant a second stent, but you need to predilate the disease. You see that if there is dissection, you may change your way of working. So you implant the first stent from the left main to the circumflex, and then you end up over there. Most of the time, I can tell you that we have a very smooth procedure because we enter with the clear-cut ideas regarding the fact that if there is tight disease, we predilate. Yeah. If there is a lot of disease around the bifurcation or we see that there is plaque shift from one side to the other, we perform pre-kissing. Then we implant the first stent. In which direction? In the direction in which there are higher chances to do not have occlusion in the other side. This means that I do not decide before intervention. I predilate if it is Medina 1-1 lesion on the left main, large circumflex, I predilate appropriately. And after predilation, I decide to stent toward the LAD or toward the circumflex according to the result I achieved. If there is dissection toward the circumflex, I go left main to circumflex, and then I end up with rewiring, kissing, and second stent inside the LAD. And this is a very standardized way we teach our fellows in doing, and I can tell you that is very effective. And the fact that you follow always for simple or complex cases one way of working allows you to know very well the reaction of your balloon, the reactions of your stents, your wires, and so on.
Francesco, kindly, you know, Medina, it's a very good for classification of the bifurcation lesion. It can work in left main, or you need imaging study like IVUS with Medina classification to choose a proper treatment strategy for left main bifurcation.
So I think that IVUS is IVUS or OCT because we almost substituted IVUS with OCT in our cath lab, honestly. However, imaging is the eyes of the interventional cardiologist. So anytime you have a doubt, you have to wear the glasses. So if you do not have doubt, go on with your procedure. Anytime you have a doubt, and doubt can be, what is the size? I mean, I see a lot of plaque, the vessel is suboccluded. Is there, or I see AZ lesion, is calcium, is thrombus, so on. So all the time you have a doubt. I think that left main is the situation in which you should not have doubt in any stage. So honestly, we use sometimes OCT since the beginning or IVUS since the beginning when we have a doubt. Alternatively, we skip and we check during the procedure. Sometimes we just do it at the end to see if the final result was good.
We have many questions, Prof. Francesco and Dr. Sameh. I would like Dr. Ibrahim to answer this question from Dr.
Dr. Francesco سؤال واحد بس.
Yes, in English.
Thank you, Dr. Francesco, for your presentation. This elegant presentation. I'd like to ask you, what about how long lesion in the side branch can be treated by provisional stenting? About the length of the lesion in the side branch can affect your decision?
I understand well. The problem is that there is no cutoff for that. I have to tell you that inside the main vessel, I do not accept any imperfection. In the side branch, sometimes I accept to have some stenosis. Okay. So it is a patient by patient difference, a decision. and that should take in account also the clinical conditions, the possibility of the patient to be, to adhere to double antiplatelet therapy and so on. So, and the length of the disease is the one that may more often make me change from single to double stenting, because to have good result, you need a stent to cover a long lesion. So I showed you cases in which tight lesions, which are very short, can be fixed very well with provisional. Regarding, it is not a magic touch. So if you have a long disease and you want to stent in this patient also this vessel, it makes sense that you implant a stent as well. But provisional allows you to do.
Okay.
If a result after ballooning or pressing a balloon is marvelous, even a long lesion, I need to stent?
Yes, I accept sometimes you implant the second stent, it's fine. If I have an important diagonal, 302.75 with 20 or 30 millimeters length, I'm very open to implant a second stent. If it is young, if it is, I'm treating a 90-year-old patient presenting with acute MI, honestly, I will most of the time accept bad result in terms of stenosis, but good TIMI flow.
Ibrahim, actually, the side branch, we have seen the cases of Francisco tonight. The side branch is not all the time the LED rather than the diagonal, or the LED instead of the circumflex. The side branch or the main distal vessel is a vessel that has a larger size, extends too long behind the bifurcation, supplies has a good blood flow and supplies a lot of myocardial mass. So this can be changed from case to case. Francisco tonight started the diagonal and considered it as the main vessel with the LED, not the LED the main vessel. And again, he is saying now that circumflex sometimes, if I am dealing with left main disease, I sometimes put the stent first in the circumflex. So you have to consider all the sequences, what is the size of the vessel. The second thing, if you have to consider or to put in your mind, the side branch that I have to treat first is the side branch that is difficult to re-access it or to rewire it. This is very essential. If the disease in the side branch extended for than few millimeters, as the case of the diagonal we have seen tonight, this is a side branch which is important and difficult to rewire. I have to consider it if the disease extends to few millimeters distal to the origin of the vessel. While the ostium, the lesion just at the ostium may be dilated with kissing balloon and may improve. So there is no definite definition to apply for all patients and all segments of the coronary circulation. What do you think, Francisco?
Perfect. I have no further word to add. I think that you summarized well. I think that let's imagine a patient in which whom you have a previous MI with Q waves in all the anterior leads, and then she presents with mild LED lesion into the ostium and tight circumflex ostial. I think that it is clear that the main vessel for this guy will be the LED, and during your procedure, if you lose transiently the flow inside the LED, you will have no detrimental consequence on a hemodynamic standpoint. If you lose circumflex, you will have a nasty condition. So,
yeah, especially if it is dominant. Okay.
Yes.
Yeah. We have many questions from the audience. Shall we start?
Yes, please.
Okay. So Dr. Tariq Dabash is asking.
أحمد مجدي لو سمحت يا باشمهندس أحمد مجدي لو الدكتور محمد مسعد عنده سؤال وعاوز يشاركنا فيه. Okay, just put the question, Mansour.
Okay, so Dr. Tarek Dabish is asking about, can we start a provisional stenting in all types of bifurcation?
It is basically what I do. So yeah. It is not can we. The problem is that we can do, but the problem is that we should realize that the procedure will be complex if the lesion is complex. So provisional doesn't allow you to do it in a simpler way as compared to what is possible. Okay. So if you have a lot of disease, you may do, because I think that pre-dilating properly, implanting a good stent inside one of the two branches, performing POT, all of these allows you to have more successful two stents at the end in the case it is needed.
But Dr. Francesco, DK Crush 5 trial has clearly shown that there is a superiority of two stents over one stent of the provisional stent. How can you explain?
It is true, but I don't think that the provisional that has been done was optimized provisional. If you review those papers, you will find that there are occlusion of the side branches that have not been rescued. This doesn't happen in my cath lab because we have the technique. We know that if we have problems with provisional, we may rescue the side branches. So I don't think that provisional has been done like I was telling you about with all these techniques. For example, side branch was not pre-dilated most of the time in this trial. So I think that those operators were fantastic DK crush operators, while they were not probably updated with the provisional technique.
Okay, so I have a question for me, and from practical point of view. I think you illustrated nicely how to get the distal stent strut, which is the must. I am doing the same technique in almost all times, but however, in many times as well, I am not sure that I recrossed the side branch from the distal. How can we be sure about that?
Okay, so to be sure, there is one gold standard, and the gold standard is OCT.
If it is not available?
So if you perform OCT inside the main vessel, you may check where rewiring happened. Okay. However, in my daily practice, I do not perform OCT to check. Okay. What I do 100% of the time is I select a balloon after rewiring, which is the balloon sized for kissing and not an undersized balloon. So this means that if it is 2.5 or 2.75 or 3.0 side branch, I select the appropriate balloon. If the balloon doesn't cross, in the absence of evident obstruction, so for example, calcific lesion undilated or something like that, most of the time, this means that I was not successfully rewiring. So I retrieve the balloon, I leave my wire there, and I take another wire and I rewire once more, being with a different bend in order to go more distal. I can tell you that more than 90% of the cases, I will be able to go with the balloon.
Okay. Sامح would like to read the question.
Sorry, Mansour.
Yeah, please.
One of the audience is asking, is kissing a balloon mandatory after provisional stenting?
Okay, so it is completely not mandatory. What is mandatory is POT, because POT allows you to fix the main vessel in the most appropriate way. And it is also able, I showed you the bench test showing this, that it removes most of the stent struts jailing the ostium with the last generation. So you really you do a good job. What I feel is the fact that in the case we need to perform side branch dilation, kissing balloon is still the gold standard because allows you to avoid inducing distortion inside the main vessel. Okay, I showed you because kissing has been documented to allow you to correct the malapposition that is induced by side branch dilation. So for this argument, I use systematically when I want to dilate the side branch, the kissing balloon inflation. The alternative is to perform side branch dilation and RePOT, but RePOT is effective only if you really reach the carina. So you take the risk to have again carina shift. This is why I don't like it.
Is there any more questions?
There are a lot of questions. Also, I think related to this same question that we answered right now, in left main bifurcation, when the strategy to stent is planned, which bifurcation technique is preferred in the left main?
Well, again, I can tell you that a situation in which I know that to fix this bifurcation is to stent technique. What I do is to perform the predilation implantation of the stent into the axis of in which it is more difficult. Most of the time is left main towards circumflex. Then I perform a POT, rewire, and I implant the second stent inside the LED according to tap or culotte. Okay. It depends on how good is the visualization of the ostium.
So if you choose the provisional stenting in left main across the LCX, is it mandatory? This is a question. Is it mandatory to kiss in this situation or not?
Yes, for me, yes, because I don't want to jeopardize the main vessel, which is, the main in terms of myocardium supplied. So I really think that the situation in which you need to open the stent struts. We recently, if you look at the very last consensus paper by EBC published in Eurointervention a few months ago, we showed the fact that it is possible that if you leave stent struts in front of a side branch, it is possible that you will have neo-intima covering that creates multiple holes. Okay, so this phenomenon is a new phenomenon that has been described, and this really needs years to happen, but I don't want to jeopardize LED into the future of these patients. So I accept the risk that in the case of dissection, I will add another stent. So
and what is the size of the balloon to use to dilate the LCX in this situation? Is it 1-to-1 or is it according to Finello or what?
So the more important is the bifurcation. The more diseased is, the more I am ready to implant to stent. And for this, I like very much to use 1-to-1 because it allows me to understand if a stent will expand. So at the end, I will just implant a stent in the case.
Okay, nice. Dr. Sameh?
We have spoken too long about the provisional stenting, and I think we should not forget that planning two stent techniques from the first step of our bifurcation lesion if we have a large side branch vessel that is supplying a good amount of myocardium or supplying collaterals to a totally occluded vessel, other vessel or other branch there, or if the side branch has a difficult access for rewiring, if it is tightly diseased, if it is long disease, we have to put in mind that we should consider two stent as our first strategy during PCI for bifurcation lesions.
Okay, so what is your...
Do we still have questions?
Many. I have many.
Fully agree with that. What I'm trying to deliver is the message that you may do this also with the flow of provisional you may use the flow of provisional to have effective double stenting, because all of these steps, POT, kissing balloon, are all phases that allows you to improve. If you reflect on the best practice for intended double stenting technique like decay crash, we know that we need to perform two kissing balloon inflation, and we need probably to perform 2 or 3 POT. So all of this is part of what I am proposing as also the flow of provisional.
Yes, I know. It is clear now that provisional does not mean that you will not put another stent. It is just a step in the route. Okay, so you are free to put the second stent at any time. So provisional does not mean that you will be prevented from putting the second stent or complete treating patient. Excellent.
Perfect.
My favorite stent. A lot. My favorite stent, Dr. Francesco, is the Ultimaster stent because the widest stent strut design. So is there a question to you? What is your favorite one?
My answer is that it is very important to do not select the stent just for bifurcations without thinking about. In this regard, I think that Ultimaster is good, and there are other drug-eluting stents which are very nice. I mean, they are very suitable for drug-eluting stent for bifurcations. So it is important that you know well among your stents, the stents you have available in the lab, which are the most suitable for the bifurcations you are treating. Honestly, I think that the main aspect we should have in mind is how the stent platform are mounted on the balloons. I mean, there are different sides of platform which are much less as compared to the number of balloons. So it is important that you know the limits of expansion of the stent for each size of balloon. Okay, so in the lab, we have a chart in which we know that for Ultimaster, for example, the large stent, the most expandable stent is 3.5 and 4 is the same, and the smaller is for 3.0 and smaller. This means that if we are treating a large bifurcation, we will think about the fact that the platform 3.5 will be different from 3.0. Sometimes it's important, especially if you are doing a culotte or something like that, in which you need really to expand a lot one of the two branches into the proximal main vessel. So to know well the expansion limit and how they are mounted is important.
Excellent. Dr. Sameh?
I think it's a very heavy meal tonight, and actually enjoyed it. We have been here for probably 1.5 hours now, and Francisco, he got tired from our questions, but actually we enjoyed your talk. We are very happy to have you tonight, and looking actually forward to seeing you in the near future during other courses we are carrying out, inshallah.
Okay.
Thanks very much. Okay,
thank you.
The floor for you.
Thank you very much. I have to tell you that my family knows the fact that if I have a pitfall and a defect is the fact that if I am talking about bifurcations and interventional cardiologists, I cannot stop at all. So but now it is time that I go for dinner. I hope that the audience got benefit from this discussion. I think that you really all helped me in delivering the correct concept I had in mind, because sometimes with slide you are not able. So I think that this discussion was very fruitful for your audience, and keep working, and I hope that in the future we will meet each other on live. Okay?
Definitely, but we need to meet in Egypt. Have you ever been to Egypt?
I went last year. You should have in mind last year. I mean, before into I went into your your measure meeting. Yes. So.
Oh, that's good. Okay.
Out of bifurcation, Dr. Francesco, how is the COVID status right now in Italy?
So we are now facing some improvement, but still there are a lot of cases every day. This means that the improvement is related with the fact that there is no further exponential increase, but still there is a steady state of new cases, and our healthcare system has been able now to organize to react to this. It is different as compared to the start, in which you probably saw all the nasty images in which we were not prepared. For example, now in my hospital, we are COVID hospital, and we have one cath lab which is equipped with different doors to enter and to escape in order to have safe treatment of patients who are COVID positive. And now we are also getting vaccine. So we are also happy for that, and we hope we will improve in future. Okay.
Yes. So now we are
after yourself. Look after yourself, please.
We're excited to listen to Dr. Ibrahim Yassin.
Yes.
Okay.
So Dr. Ibrahim, please. Dr. Ibrahim is one of the, I think 2 years ago, we were calling for him as a rising star in intervention cardiology, but I think right now he is a real star in intervention cardiology. So Ibrahim, please.
Thank you.
Okay, so I will continue hearing, but I will do it with my family aside, because my daughters are waiting for me. So I will be connected but I will switch off the video. Okay. Thank you.
Enjoy your.
Okay. Thank you so much.
Enjoy your dinner, and we are waiting furious. So Ibrahim, please.
Thank you.
Okay. We need to conclude. Ibrahim, do you have a comment?
Thank you, Ian. And in conclusion, بس حضرتك احنا shall we can continue today or postpone for the next week?
No, I think we will postpone it to next week. It is 9:30. It is 10:30 now. عبد المقصود.
لا أنا حقيقي سعيد جدا جدا جدا، يوم رائع وجميل، وحقيقي استفدنا منه كتير كلنا، وحقيقي أنا يعني I'm so happy حقيقي what discussed today من الليكتشرز ومن الكومنت ومن الكويشنز ومن الداتا اللي اتقالت النهارده. Thank you so much.
Mansoor?
I think it is outstanding presentation from Dr. Franco. I think just to say this, his name is to simplify his name or nickname, as you say, it's Franco. I think he's very, very simple guy, very, very nice guy, have a lot of information, and I think is happy face. I think it was extremely impressed by his behavior and his presentation as well. We are looking to see him, inshallah, in the near future as well. So very, very nice questions, very nice answers. And we were looking to see Ibrahim as well, but unfortunately next week, inshallah, we'll be extremely and excited to see him, inshallah.
الإخوة الأفاضل اللي حاضرين معانا، احنا وعدناكم ان الكورس ده هيبقى very special course، واعتقد ان احنا we are fulfilling our ابراهيم ان شاء الله باذن الله الدسكشنز مفيده، وان شاء الله في المرات القادمه هيكون الكلام احسن واحسن، والفيديو هنحاول بقدر الامكان ان المحاضرات دي تبقى available على اليوتيوب as soon as possible. واعتقد ان احنا we will do our best next week ان احنا نطلع على الزوم ونطلع لايف على الفيسبوك at the same time. We are trying to do that, and this lecture or this wave of bifurcation will be available within very soon on the YouTube, so you can listen to it. You can realize how important it was. Thank you very much. Hoping
دكتور سامح، دكتور سامح، احنا معانا الدكتور منصور مصطفى.
فين الدكتور منصور؟
موجود على هو. قول لنا بقى كلمه ظريفه كده دكتور.
هو فين؟
طبعا اليوم رائع جدا وممتاز وفعلا
امال انا مش شايف الصوره بتاعته ليه؟ منصور
موجود معاك من الصبح يا دكتور سامح.
ظهرت يا بيه، ظهرت يا بيه.
مع حضرتك من بدري.
ايوه منصور، اتفضل يا حبيبي اتفضل.
ظهرت حضرتك ممتع.
لا انا مش سامع يا ولاد، انا مش سامع منصور ومش شايف.
في مشكله عند حضرتك يا دكتور سامح، ما احنا سامعينه اعتقد. انا سامع.
طيب
اتفضل يا دكتور منصور.
هو من ميزات صراحه كانت المحاضره سيمبل قوي، وكان كلاريفاي، وكان ديسيجن ميكر في حاجات كتير جدا، يعني في حته البوت، في حته السايد برانش، في حته ان الناس ما تخافش ان تعمل بري دايليتيشن. ده حقيقي دي، يعني كانت ناس كتير جدا تتخوف ان يحصل ممكن دايسكشن. فهو في برضه مختصر المحاضره انه بيقول لك انت شايف الفيلد قدامك، انت ايه البروبر فورسبيشن، يعني فعلا السايد برانش كبير ممكن تعملي بيفوركيشن غير السايد برانش بيفوركيشن. وكمان وضح جدا حضرتك ان هو جزئيه البروفيشن لما اتعامل صح فعلا اللونج تيرم بتاعها افضل بكتير. حضرتك يا بيه كان ابراهيم بتاعته ابراهيم متميز حقيقي، يعني حضرتك كان يعني يتحط فيهم حتى وحده مع لايف كيس، بحيث ان يبقى الاستفاده كامله، لان ناس كتيره جدا منتظره. النهارده مش اشكال بالنسبه لنا الوقت، يعني احنا قفلنا العياده خلاص. ممكن نقعد في ساعه كده. فحضرتك هتبقى الاسبوع الجاي ان شاء الله ابراهيم وحاله.
بص يا منصور، هو انا خدت قرار ان هو ابراهيم يأجل محاضرته للاسبوع الجاي بناء على طلبه، وبعت لي رساله وقال ان هو enjoying الميتنج، وبناء عليه انا خدت القرار ان احنا يعني it was his decision، وانا اعلنته. دي نمره واحد. نمره اثنين، احنا ان شاء الله الاسبوع الجاي ابراهيم هيكلم لنا على البروفيجنال، ومحمد مسعد هيقدم لنا حاله ليها علاقه بالشغل برضو ان شاء الله. والاسبوع اللي بعده برضو عندنا محاضره، وعندنا حد من الزملاء هيقدم حاله، فهتبقى محاضره وحاله في المرات القادمه ان شاء الله يا دكتور منصور.
تمام
ان شاء الله.
ان شاء الله باذن الله.
يلا اقفل يا منصور بقى السيشن، كونكلود بقى
السلام، يعني نقول السلام عليكم ورحمه الله وبركاته. بعد اللي حضرتك قلته خلاص اعتقد البلان واضحه وكبير ان شاء الله.
في حاجه
لكن ديفينتلي اعتقد برضه المره الجايه يا ريت الفيسبوك اي ثينك يبقى افيلبل برضه ان شاء الله، عشان كمان يبقى لايف اون الفيسبوك.
هنحاول نعملها من قبل يوم الاثنين ونجربها علشان يبقى احنا ريدي وما نتعطلش.
كلام الدكتور منصور بالنسبه للحالات، اعتقد نزود حالات ذات نفسها، تيبس وتريكس وكومبليكيشنز برضه ذات نفسها، والديفيكالتي اللي بتحصل والريكروسنج والقصه دي كلها، اعتقد تبقى لايف.
كل اسبوع يا دكتور منصور هنقدم حاله، ولو في حد من الاخوه الاودينس في الاسم او في البنات او في اي مكان عنده حاله انترستنج بايفوركيشن it will add to our knowledge، هنبقى very happy to accept it ان شاء الله.
ان شاء الله.
يلا يوم سعيد وليله سعيده، والسلام عليكم ورحمه الله.
تمام حضرتك دكتور سامح.
اتفضل
دكتور سامح.
نعم.
سلام.
امين.
حضرتك نتمنى لو حد عنده حاله مثلا عملها وكانت انجيوجرافيكالي جود اثناء الاكيوت اوتكم، يا ريت لو عمل لها مثلا قسطره بعد سنه او اتنين، او في اي كان كومبلين وصورها تاني وشافها، يبقى شيء كويس جدا. نقول الكلام ده فعلا بنشتغل على الرايت واي، ولا جاست الاكيوت ريزلت، زي احنا مش كل الناس برضه بتهتم بالاوتومايزيشن في الشغل بتاعها.
ان شاء الله
يبقى شيء جميل يعني ان شاء الله.
ان شاء الله. يلا السلام عليكم.
يوم سعيد ان شاء الله. السلام عليكم.
يوم سعيد علينا وعليكم جميعا يا رب ان شاء الله. الف سلامه. مع السلامه.